Let's get ourselves, how do we get, there we are. Okay, you wanna go around?
There's a blister maybe on ankle skin.
How do we get it so we got the pointer showing on the screen?
We need to hit the function.
Find the common area.
Function and
Or we can just change
Function
the way this
F8?
works. Yeah. And then switch to like just duplicate.
there we go.
And now you'll just duplicate. So we have to get out of this presenter view. So
Okay.
hit escape.
Escape.
And then
And just here again.
under.
Here we go. We got it. Ta-da, thank you. Okay, so you got a cyst, and in the wall of the cyst you got cartilage, you got glands. So, anyone quick? Bronchogenic. And where on your neck is that going to be? Lateral. Yeah. Or branchial cleft is the most lateral, then bronchogenic, and then thyroglossal, central. So correct. Branchial cleft, most lateral, then bronchogenic, and then medial thyroglossal. And then you'd expect pseudostratified ciliated epithelium, sometimes with goblets. Okay, so little girl from South America, and those are her cutaneous lesions, and that's her biopsy. So what do you think? So what do you think? What do you think these cells are? Lymphs. What shape should lymphs be? Are these round? And they do. There's not a ton of rimming, but those are bizarre lymphocytes, right? They are bizarre shapes and hyperchromatic. So, what do South American or indigenous Amerindian type populations get? Especially if she had stuff on her cheeks and ears that look kind of photosensitive. Yeah, hydroa-like lymphoma, which is EBV driven. So that's the EBR. Everything's positive. And the fatality rate is very high. And traditional chemo, they get temporary remission and then rapid demise. And unfortunately, she was taken to one of the cities where she was treated with traditional chemo and had temporary remission and then died. So, okay, next. So, see follicular plugging, glassy-like acanthosis, trapping of elastics, so there's some degree of PEH there, and vacuolar interface. Put it all together, what are you thinking? Hypertrophic lupus would be the most likely, especially with the bit of vacuolar interface. The other thing you'd want to look for is verrucous zoster looks very similar. That's always immunosuppressed, usually undiagnosed HIV. They're warty lesions disseminated on the body, and when you biopsy them, you have almost keratoacanthoma-like hyperplasia of every follicle, and then within the follicular epithelium, herpetic multinucleated giant cells. So in this case, with the interface, hypertrophic lupus. Where should papillodermis end? Probably about there. It ends here. So big widened papillodermis, stringy, ropey collagen, lymphocytes lined up between those collagen bundles, lymph in every hole. There's CD3, CD8, so it's heavily 8, which usually goes with hypopigmented MF then. Yep, IFK or irritated seb. It depends whether you consider this more exo or more endo. If that's your skin surface, that's kind of endo. If your skin surface down there, then it's exo. So you can make it which one you want. So these are all, dyskeratosis, I heard. These are all grains and corons, so your differential. Grovers, Darier's, warty dyskeratoma, or vulvocrural dyskeratosis. In this case, it was just TAD. Yeah, so if there's neurovascular bundle here, then it's a NIDGET. And if it's just collagenous, then it's an angiokeratoma, which on the digits we call acquired digital fibrokeratoma. Right? It's just another form of angiokeratoma, which when multiple goes with TS, like any other multiple angiokeratoma, and when solitary means nothing. Okay, how about this? Yeah. Subacute fat necrosis, you see all the radial clefts and granuloma. What else? What if this were an adult rather than a kid? Post-steroid fat necrosis looks similar to subacute fat necrosis of the newborn. How would sclerema look different? No granuloma, and it's unfortunate because the children probably die too fast to mount a granulomatous response.
So is the post-steroids, when they get like systemic steroids, is it like a diffuse thing, or is it?
Can be localized or more diffuse. It's similar to what happens with, you can get fat embolism after steroid. The necrosis of the hip may relate to fatty embolism. I heard bug. So you got something here, right? And it's kind of stippled. So it's microfilaria of some sort, right? And it's not obviously in a lymphatic. It looks like it's out in the dermis. And so in this case, strongyloides. Match it with the clinical. In this case, it might be thumbprint purpura on the abdomen, or larva currens, which is sort of rapidly migrating thing going from your anus out to your flank. Urticarial trail that can be a centimeter an hour. And strongyloides is often fatal if disseminated. So, especially in warmer climates, patients become immunosuppressed and develop disseminated strongyloides with thumbprint purpuric lesions. Broad vertical streaks. Yeah, so perforating disorder, and this one is an RPC pattern, reactive perforating collagenoses. EPS is a narrow serpiginous channel with altered eosinophilic elastic being spit out. RPC is broad with vertical collagen being spit out. RPC is the most common pattern of acquired perforating disorder of renal disease. but inherited RPC would look exactly the same. It tends to be areas of minor trauma like needle stick from a blood draw. And there you see the collagen. Where on the body do you think you are that you have this kind of nodular angioplasia? Probably shin, hyperkeratosis, acanthosis, nodular angioplasia. Name 3 brown pigments in skin. Melanin, hemosiderin, lipofuscin. Which one is this likely with the nodular angioplasia? Hemosiderin, so what is this? Stasis. Scabies picnic. Yeah, some kind of porphyria. So alopecia with miniaturization. Is it scarring? Nah, you got all your sebaceous glands intact. That would be the first thing to drop out in a scarring alopecia. You have some variation of follicular diameter, so most likely pattern. Also look carefully at your fibrous tracts for any pigment incontinence, eosinophils. So I heard KS. We have promontory signs, and you're a little busy around pre-existing structures. So you got a pre-existing structure and it's jutting out into a cavitary space. You're busy, and in the center of every busy, you've got a pre-existing vessel or structure of some sort. And so that is in fact KS. So what's bone, right? So it's osteoma cutis sitting in a follicle, so it's probably post-acne miliary osteomas. And this one even has marrow. You do a little marrow biopsy while you're there. Got myrmecia. You have the big granules. Yeah, convoluted worm, pathetic little muscularis. She's gravid. So Onchocerca, we're humans' definitive host. And that is right there. That's another little. That's one. Here's one. All little microfilaria and tissue. So onchocerciasis. What do you think this one is? So pale blue hypocellular surrounded by more hypercellular adult myofibroma. Schwannoma would be encapsulated with a crescent-shaped zone of subcapsular edema. Lupus, follicular plugging, hyperplasia of epithelium, vertical columns of lymphs in the mid-dermis. Lupus. Masson's change, you're within a cavity that's a vessel, and you have hyaline cores. When they're young, there's fibrin in the core. Hyperkeratosis, massive papillodermal edema, band, lichen sclerosis, Chirpies. Yes, you have lots of multinucleate cells with the peripheral rim, basophilic rim of eggshell-like rim of chromatin. So herpetic cytopathic effect. So I heard cocci. Is it lacy or is it kind of amphiphilic? So what else did I hear? An alternate? Lobi, leprosy. Right there, your red snappers. So go back. That's the appearance of globi. So rhinoscleroma would look exactly the same with rods forming globi, except you'd be on a background of sheets of plasma cells with Russell bodies. So Lepromatous leprosy. Lots of little circles. Leishmaniasis, like bulbs on a makeup mirror or movie marquee around the periphery. Leishmaniasis.
We talked about in one of the AD sessions about kind of the difference in the organisms of pollution, like this, it's not just always the wrapping around, but you can actually tell with the.
So sometimes you can confabulate a kinetoplast
Yeah.
in it. So histo has a pseudocapsule. It's not a real capsule, but it makes them sit even distance apart. Whereas leash tends to cluster. So see the way these are clustered at the periphery? First off, leash normally has a marquee sign,
Right.
but they do cluster. The closest lookalike for leash would be Penicillium, which is no longer Penicillium, Marneffii. It now has a new genus, but Marneffii looks very similar to leash in terms of clustering and not being evenly spaced the way histo is.
They gave us a virtual slide that had bubbles, with organisms inside of it. They were not all not many marquee very well.
I see,
So
okay.
that we should have been able to tell by the organismal appearance, because this and leash were on the.
Did it have a kinetoplast?
What's that?
Did it have a kinetoplast?
Well, I mean, it was a virtual slide. I didn't examine it.
Yeah, and
I couldn't
and the
picture all of it.
kinetoplast, I mean, it would have to be a very good oil image really to see a kinetoplast. And even then, you have to be on drugs sometimes to see that. I'm not sure that would be very fair to ask you to distinguish. Amyloid, epidermally derived with the pigment, and lichenified skin, so lichen amyloid. It's sweaty, right? So it's a sweaty tumor. Little brown white things that are duct differentiation. It's about the same color of the epidermis, so it has both nucleus and cytoplasm. If you looked higher, you would see probably that it doesn't palisade, so it's acrospiroma, poroma, hidradenoma, all names for the same tumor. Has ample cytoplasm, right? And the poromostroma, which looks like osteoid with little blood vessels in the center. So acrospiroma group. LCH, very good. So you, what are the black cells? Lymphs. So what are the gray cells with vesicular nuclei? Histiocytes. Histiocytes behaving badly at the level of the infundibulum is LCH. Newts behaving badly at the level of the infundibulum, folliculitis decalvans. Lymphs behaving badly at the level of the infundibulum, LPP. Histiocytes behaving badly at the same place, LCH. Usually eosinophils and edema present. So Langerhans cell histiocytosis. And if you wait for reniform nuclei, you'll miss the diagnosis. How old's your patient? Very young, very red, small collagen, lots of fibroblasts. So young patient with something very verrucous with lots of dead reds. This is IP, incontinente pigmenti. Looks very, very similar to subungual keratoacanthoma. In fact, there's some evidence that at least some subungual keratoacanthomas are postzygotic mutation for IP gene. What's that? Hyperplasia of multiple follicles, all with hypergranulosis. Early keratoacanthoma, absolutely. Where on the body? Acral. Reticular degeneration acral site, probably. Coxsackie, hand, foot, and mouth. That's all corneum.
Yeah.
So.
Oh, and then pour out like Ticotropia.
Oh, poor Trichotropica, but we're really,
Harlequinic
yeah, more like harlequinichiosis. Granzones, so this is granuloma faciale. See how it forms little squares because of the granzone, and you can see the little red things in there. So where's the granuloma?
And then
In the name, not in the tissue. Okay, and higher power, it's an LCV. Glomeruloid hemangioma, that looks very much like a glomerulus, and you'd expect little mummified degenerating erythrocytes in it. And associated with Poems syndrome. Yeah. Gel foam or Instat or whatever collagen matrix you use. EDV, epidermal dysplasia versiformis, coarse basket weave corneum, and bubbly blue cytoplasm without sun protection. What's their lifespan going to be? Maybe 20s, maybe 30s if they're lucky, dying of metastatic squame. With sun protection, they can live a normal life. So they only develop the squames where they also have sun exposure. And they develop them at a rate similar to xeroderma pigmentosum. Dowling Dagos. Looks like reticulated seborrheic keratosis hanging off every follicle. Reticulated pigmented anomaly of the flexures. And what if you have acantholysis? Golly, who described it first? Golly. Right. Yeah, poor whiner or pilar sheath acanthoma, depending how fat the fingers are. Poor pilar sheath acanthoma is just a fat poor whiner, right? So these are a little chubby. So pilar sheath acanthoma. Dyro, so big host response, big studly muscularis, bachelor accidentally in the skin. So it's Dyro, not like the pathetic little muscularis of the married Onchocerca. Okay, if that helps you remember it. So I heard Botryode. Is Botryode going to give you clear hollow tubes all through it? No. This is, and what color is out here? Brown. So this is black mold mycetoma. So it's in an erectopyle ended vessel, so it's a vasculotropic fungus, and it has chlamydospore, and it has visible cytoplasm and a very delicate wall. So I heard fusariosis, which is correct. And that means what drug are you going to go to? Voriconazole, right? How would aspergillus be different? No chlamydospores in aspergillus. How would black mold be different? Thick refractile wall instead of the thin delicate wall. And how would mucor be different? Red hyphae, hollow. So that's fusarium. What's this one? Coxy. Either endosporulating or lacy blue cytoplasm. Either would be diagnostic for Coxy. Blue nevus, very bulbous bottom. Follicular mucinosis, very good. Colloid milium, fissured, pink, transition from the elastic to the colloid material. So a blister with what kind of degeneration causing the blister? Ballooning, and it loves the follicle, so probably varicella zoster, but probably this tiny little dewdrop on a rose petal is probably varicella. And there's your viral cytopathic effect. Where should your papillodermis end? About there. So you got a widened papillodermis. It's busy. There are eosinophils present and gray granular cells that are somewhat elongated, spindled, chunky, brick-like. To me, they always look more like bricks than spindles. What's going to be gray amphiphilic cells, busy in your papillodermis and attract eos? Yeah. So what is this?
T-Map?
TMAP. Well done. That's exactly what it is. So there's a mast cell tryptase, a telangiectasia macularis, eruptiva perstans, mastocytosis. Perineurioma. Well done. Sclerosing perineurioma. See the onion skin. Like, they're typically amphiphilic and onion skin-like fibrosis around a central little neuron. So, sclerosing perineurioma. Two things that could look like this. Both of them would be in kids. Both of them. So giant cell fibroblastoma or rudimentary meningocele. That's exactly right. So both of those can give you these collagen balls surrounded by, see that little gray thing around it? That's the cytoplasm wrapping around it. So collagen balls with cleft-like, vascular-like spaces, wrapping of the cell processes around the collagen balls would be either rudimentary meningocele or giant cell fibroblastoma. What does giant cell fibroblastoma grow up to be? DFSP, fibrosarcoma, correct. So it's juvenile form of the fibrosarcoma. This one was EMA positive and was rudimentary meningocele. So pigmentation, very hyalinized vessels, big angiectoid vessels, pleomorphism. So do you know any kind of pleomorphic hyalinizing angiectoid tumor? Yes, it's called pleomorphic hyalinizing angiectoid tumor. FAT, PHAT, fat, pleomorphic hyalinizing angiectoid tumor. The similar vessels you can occasionally see in spindle cell lipoma, but they're very characteristic and kind of lead you towards fat, pleomorphic hyalinizing angiectoid tumor. And you can have hemosiderosis also on there. If you look way up at the top, it says fat, PHAT. Is your dermis normal or is it busy? And is it top heavy or bottom heavy, busy? Bottom heavy and into the septa. What's bottom heavy, busy into the septa? NSF. And these are the lollipop bodies. Okay. What's busy, top heavy? Scleromyxedema. GA would be patchy, busy. So busy, top heavy, scleromyxedema, look for paraprotein. Busy, deep into the septa, nephrogenic systemic fibrosis. And then these are the lollipop bodies, or this one looks more like a balloon on a string, right? The string or the lollipop stem is the elastic fiber sticking into the osteoid. So if you see all this osteoid in the deep, busy dermis, you can say it is a bona fide example of NSF. It's a tough room. Okay. What's that? Melanoma, absolutely. So name 3 brown pigments in skin. This one is more likely melanin because these things don't mature And although they kind of at first glance look like they disperse, they're really going in parallel theques. Do you see any white cleft at all between the collagen, in between those parallel theques? No white space, no white clefts. That means that collagen's squashed by something expanding and crushing it. Right. So the typical look of parallel theque of melanoma is horizontal at the base, no white space between the collagen. In a nevus that disperses, you're always going to have white clefts between the collagen, clearly lamellar. Here the collagen's crushed. And then here's another parallel theque. Flat bottom red fibrosis, confluence at the junction, horizontally oriented nests, no white space, no white clefts in the collagen. Nerve sheath myxoma, neurothekioma. So myxoid neurothekioma, which is the same as nerve sheath myxoma. Big islands, pools of mucin snot with stellate cells. Okay, so when you see that, then it's not hard. Okay, so what do you think? So I heard spindle cell lipoma. Do you see ropey collagen in there? Spindle cell lipoma has got to have ropey collagen in there. And I'm really having trouble finding it. What do you think? So is that just a regular lipocyte, or is that more like a blast? Like a mulberry lipoblast? So now I'm looking to see, is there an arborizing chicken wire-like vascular pattern? Because I'm worried about liposarcoma. Right, and you've got all your blasts here, and this is liposarc. So, I heard myoparasitoma, which is dead on. Very good. So, myoparasitoma, you have the blood vessels, and around them the rosettes of these round, pale epithelioid-like cells. So that's myoparasitoma. That's a beautiful picture right there. Crust. Can you make out your reedy, or they're lost in the fog? London on a foggy day. What is this? C for this, right? So busy dermis, London on a foggy day, syphilis. You got lots of vessel. Where's your lumen? No lumen, right? Reedy. Can't see them, lost in the fog. And then plasma cells, if you're lucky. I think I heard meningioma, which is exactly what this is. So you have these kind of epithelioid whorls of cells, and then you might see some homobodies in there. Ta-da! So all of these meningothelial whorls and small bodies. Meningioma. So what's that? Leprosy. And auramine rhodamine is your best stain. So you are going to see leprosy in your practice. It's out there, right? And you will have someone just with an indurated face or with papules, and you're going to see these amphiphilic, round holes full of amphiphilic stuff. So if someone hands you a box, what's your question? What's in the box? Someone hands you a dermis full of holes, what's your question? What's in the hole, right? And in this case, it's kind of amphiphilic, rod-like stuff. See how it's rod-like? Lipoid proteinosis. All of the heavy hyaline mantles split vertically around vessels. And the patient talks like this because it's in their vocal cords as well. Right, so that's lipoid proteinosis. You'd expect the little pearly things, little string of pearls along the eyelashes. A little row of hooks, exactly. So that cysticercosis, hydatid, a kinococcal cyst. EHK, massive hyperkeratosis, granular, blown full of holes with both red and blue granules, epidermolytic hyperkeratosis. EDV again, very good. You just saved that patient from a horrible death with squamous cell carcinoma. Well done. So myxoid DFSP, or what looks just like myxoid DFSP in growth pattern. Diffuse neurofibroma, so if the patient has von Rex, and those are wavy, diffuse neurofibroma. What's that? Polarization in the vessel lighting up. Cholesterol embolus. Branchial cleft with lymphoid nodule. Remember, the lymphs are lateral, so it's the more lateral in the neck. Lymphs lateral. Okay. We have 4 minutes. What do you want to do in the next 4 minutes?
Path 6.
Dermpath 6. How about Dermpath 4? Because I'm putting together Dermpath 6. Okay. What's that? Schwannoma. Round encapsulated crescentic zone of subcapsular edema. That's about how long it should take you to make the diagnosis. Schwannoma. Are the lipocytes all the same size? No. Little fibrotic towards the septum, pleomorphic cells by the septum. ALT, atypical lipomatous tumor, low-grade liposarc. It's something bloody, right? And then when you look at the vessels, are they cleft-like or are they round? Lots of tiny little round things. So what's going to give you this big vascular tumor with tiny little round vessels and all of this funny, smudgy stuff in it? And neutrophil debris by the smudgy stuff. Yeah, bacillary angiomatosis, exactly. So little round vessels like a PG, but distinctly not lobular with septi, unlike a PG. So little round vessels like a pyogenic granuloma, but no septi, smudgy stuff, which is the organisms, and neutrophilic debris as a clue that it's infectious. Bacillary angiomatosis. What's that? Calciphylaxis. Two distinct populations. That looks like tumor, this looks like tumor, and they're two distinct populations. This looks epithelial, that looks mesenchymal. Carcinosarc. Right. Both populations malignant, one mesenchymal. So both your stroma and your epithelial tumor are malignant. That's carcinosarc. So it's sweaty, like a poroma, and then this area, yeah, I mean, that looks a little worrisome, right? Like maybe porosea. But higher power looks like spiroadenoma, cylindroma, spiroadenocylindroma, peppered with lymphs like a spiroadenoma. clefts in the stroma. Yep, papillary mesenchymal bodies. So trichoep. That's a beautiful papillary mesenchymal body, right? Just love them. Okay, what's this? Jigsaw puzzle. Cylindroma. Breast, metastatic breast CA. Bednar, well done. So, storiform, pigmented dendrites, Bednar tumor. Sheets of cells breaking up into single file. Rim of pink cytoplasm, you are correct. Leukemia cutis at scan. CD3 negative, CD4 positive, that disconnect. CD4 positive like a T cell, but CD3 negative, that's leukemia typically. Or blastic plasmacytoid dendritic cell neoplasm. And this one's CD123 positive, so it's blastic plasmacytoid dendritic cell neoplasm, which either is or isn't primary cutaneous leukemia. Last WHO, it was leukemia, and now it's by itself because they're not sure if it's leukemia, but it behaves like leukemia. Looks like leukemia. So, whole dermis compacted like a sweater put through the dryer. Big, broad, fibrous tracts. No hair. Elastic sheath intact. In fact, duplicated. CCCA. Yeah, DPN blue, something in the blue spectrum. It's got its own sclerotic stroma, bulbous bottom, blue nevus. And that's it. We're right at the hour. You did, how many did you do? I think you did about 300. Not bad. Sir.
For SCD, I'm presenting the 4 to 5 dermatitis that we saw earlier in the year. So we're presenting